been doing a good job of that so far. The class is just really right where it should be. I'll make a not so bold prediction that you'll come out where we are on about average for the exams we've already taken. So somewhere in the 80s, and that'll carry over into the fourth exam also. So you're right on schedule to wrap up this semester in a very beneficial way, and really encourage you to as much as possible de-stress things, so that you've got just the right amount of attention for the exam, but not so much that it overwhelms in a stress-based sense. Okay, with that, see if anybody has come up with any questions or comments. Oh, and also, I mean, it just goes without saying, I suppose it's nothing new to you folks, but I think, you know, those of you who like to study together, that's a really great idea. Not everybody likes doing that, and that's fine. But if you like to study together, I think that's a tremendously powerful tool. And one of the things you can do, I've probably mentioned this before, is that you can kind of examine yourselves as you're going on. Make up a question that you think might be the type of question that would occur on the exam, and pose that to your study partners, and have them classify the agent that you're talking about, and come up with some ideas on what major effects, good and bad, there are for that particular category. And I think you can darn near write the exam yourselves by taking a strategic approach like that. And I, again, if you like studying together, I really encourage an approach like that. Okay, well, let's finish up this category of degenerative disorders that we were talking about yesterday, and starting with this really cool little picture of the kitty getting a umbrella action from the little child. And I have a black cat lying right beside me today. She's sound asleep, and I've already bored her enough that she's sawing logs. So one of the things that I wanted to bring Parkinson's back into the discussion yesterday for, along with the other categories that we talked about, was to emphasize a number of neurotransmitters that we're becoming rather familiar with now, led by dopamine and acetylcholine, I suppose, but also GABA and glutamate, some degree serotonin, although serotonin will play a bigger role in our discussions later on today of antipsychotic drugs. But to re-emphasize some of these neurotransmitters, and sort of look at how a variety of things go wrong with these neurotransmitters in these degenerative disorders. And although you might have sort of too much dopamine in one case and not enough in another, it still sort of relates to the whole idea of dopaminergic problems in terms of regulation of the transmitter. And let me point out too that, you know, sometimes my discussion of this is a little bit overly simplistic, in the sense of thinking about the neurotransmitters as just too much or too little. It's that, but it's also more than that. It has to do with more dynamic aspects of regulation for those neurotransmitters, as well as absolute levels. And of course, it's going to vary a little bit depending upon what particular subcomponents of the brain are particularly impacted by the particular disorder, such as the basal ganglia in Parkinson's disease. So let me just rifle through this. So, you know, a slide like this one, which is entitled "Dopamine in Parkinson's Disease," is the the sort of thing to emphasize in terms of thinking about between the similarities and dissimilarities of these various disorders. And certainly in this particular one here, we can see the emphasis on dopamine, acetylcholine, and GABA. We talked about how, once again, the metabolic aspects are important, as well as just the more pharmacodynamic aspects of the compounds themselves. So one thing about the neurodegenerative disorders that fits well within our overall context of pharmacology is that there are important pharmacodynamic as well as pharmacokinetic aspects to the current approaches that are taken as far as pharmacological treatment is concerned. So it's nice to be able to apply those general principles in a fairly specific way here in neurodegeneration. And at least to some degree, I think that similar joining of forces of pharmacodynamics and pharmacokinetics will occur during your lifetimes as new therapies are discovered, and hopefully new therapies that are more powerful than the ones that we have now. And I think another contrast that we saw yesterday was that in some of the areas, the pharmacotherapeutic approaches is fairly well in order and reasonably powerful, such as in Parkinson's disease, whereas in other neurodegenerative disorders, we're hardly anywhere down the pathway of understanding the fundamentals of the pathology of those particular areas, and therefore we've lagged behind in terms of development of pharmacotherapeutic agents. So there's tremendous need in a number of these areas to do better pharmacologically, and it applies to Parkinson's disease also, in the context that we're still really not addressing fundamental etiology, or seemingly we're not, as well as we need to. And when the fundamental aspects of the disorders are better understood, it's going to lead to a more rational design of therapeutic interventions in these areas. And so, as you go through your practices over the upcoming decades, I'm fairly confident that with the intensity of research that's going on right now, that you'll have more powerful and rationally designed therapeutic regimens to provide to your patients, and that's something to really look forward to. So I would expect that in your futures, as you keep up with pharmacology as it changes over the years, that the neurodegenerative disorder area overall will become a more and more important area to you, not only because of the aging population that we have in this country and elsewhere in the world, but also because of the emphases that are being so prominently displayed in research now should uncover better things to use. So it's very likely to look a little bit different than it looks today in terms of the evolution of pharmacology in this particular area. We reemphasized again the relatively inefficient availability for levodopa, and that's a consideration that leads up to the pharmacodynamics of dopa, and of course what happens in the long range for any individual who has Parkinson's disease, that eventually these interventions begin to sort of wear off and get to the point where what we have available to us is really not very effective anymore. So it'd be great to have agents which were capable of lasting a little bit longer um, in terms of efficacy relative to the ones that are available right now. So the levodopa-carbidopa combination is sort of the kingpin, if you will, of Parkinson's disease pharmacotherapeutics at this particular time. We did talk a little bit about how a more direct approach at mimicking dopamine is often utilized, particularly later. It's often up to the neurologist or other professionals that are involved in the design of a therapeutic regimen for a given individual in terms of which order these things are done. But the most common order, um, as far as I know, these days, is to start with levodopa, carbidopa, and then as that starts to become minimized in terms of efficacy, to move to other approaches, such as using direct-acting dopamine agonists, such as some of the ergot alkaloids, which are mentioned in this particular slide on dopamine receptor direct-acting agonists. And just more on metabolism, again, emphasizing a couple of prominent metabolic enzymes for catecholamines, such as MAO and COMT. And then basically emphasized on this acetylcholine, on this slide, acetylcholine aspects of it. And here we're looking at, too little dopamine, which needs to be addressed, but then too much acetylcholine. So therefore, atropine class muscarinic antagonists are utilized, and a number of examples of those are listed in the little box slide that's included within this particular slide, with a historical emphasis on benztropine as being a prominent atropine-like drug that's utilized especially in Parkinson's. Well, we then switched over to another disorder of movement like Huntington's, with the notation, of course, that with respect to both Parkinson's and Huntington's, and I wanted to emphasize it, and I'm not sure how well I did, that there are, cognitive, mental aspects to these disorders that are as prominent as some of the more commonly mentioned motor-related aspects. But both those are represented again in Huntington's, and talked about there's a little bit known there in the first bullet point about the etiology in Huntington's, although it still doesn't really adequately express all the various aspects of the disorder that are playing out over time as Huntington's progresses. But certainly in a generalistic context, you can, in terms of your thought processes, you can emphasize the mental aspects in terms of progressive and substantial dementia that occurs, as well as the motor-related problems with the chorea that is, and sometimes Huntington's is even, that is even used as a tag label in Huntington's. But the rather large movement-related things that occur in Huntington's lead to a somewhat different outlook relative to the more tremor-like aspects that we see in Parkinson's. Although both both types of movement-related things are possible in either one of these disorders. Um, so it's really interesting to note that with respect to dopamine, uh, and this is where we can really focus in more on the regulatory aspects of it. Uh, a fine balance of dopamine is required neurochemically to produce the right regulation of movement, and both too much and too little dopamine, uh, or too much and too little of acetylcholine can be a problem in these movement-related disorders. Um, I would like to remind ourselves, and I'm not sure I mentioned this at all yesterday, that when we're thinking about these movement-related disorders, there's sort of major motor control and minor motor control aspects of it, and the minor motor control is more the fine tuning stuff, and the basal ganglia are particularly important as far as that fine tuning of motor regulation is concerned, whereas the motor cortex of the cerebrum is often more critically involved in the major aspects of movement. Uh, so you can see both those so-called major and minor aspects of motor dysregulation in these movement-related disorders. And it's going to vary a little bit from individual to individual in terms of how those things play out, and in terms of how the therapeutics is how successful that is. So here's sort of the companion slide to the Parkinson's one in Huntington's, and so we see a lot of the same players, but sort of um, playing out in a somewhat different way between the two disorders. They're distinctly different disorders, even though we can easily see some relationships neurotransmitter-wise between the two. When we moved on from the pathophysiology to the pharmacology a little bit more, and here would be a strategic place for you to study. Absolutely can guarantee that there'll be questions on reserpine on the exam, and of course the phenothiazines and butyrophenones, not only with respect to Parkinson's, but with respect to our next topic in terms of the antipsychotic drugs, because the phenothiazines and butyrophenones make up subdivisions of the somewhat older class of antipsychotic drugs, but still very important in terms of application today. If you see reserpine in a question, you're going to need to sort of double classify it a little bit, or maybe even more, but certainly double classify it in terms of, well, it's the sort of drug that's useful in some types of Huntington's disease, but it's also an antipsychotic drug, although an aged antipsychotic drug. But some of the phenothiazines, such as perfenazine, which I've mentioned here, would be identifiable in a classification sense in terms of Huntington's. And so taking those strategic thoughts further, what does reserpine do? Well, we know it's a depleter and a substantial depleter of dopamine, as well as other monoamines. And then when we think about the phenothiazines, we think mostly about their ability to antagonize dopamine at dopamine receptors. Although in your lifetimes, other aspects of action of these substances may well arise, and our understanding of mechanism of action may well expand beyond the level that's mentioned in this particular slide here in 2020. So then we began to move into more problematic areas in terms of successful treatment strategies. And, and the first of those that I brought up was Lou Gehrig's disease, or ALS, in which, in my estimation, there is really no substantially efficacious pharmacotherapy available, although breakthroughs are occurring in these areas. And I think in terms of biologic types of drugs, you may well see some success stories begin to arise a little bit more commonly in these areas, and perhaps over just the next few years. So there's about 10% of ALS cases are recognizable in terms of familial carryover genetically, and particularly emphasizing aspects of oxidative damage with respect to that. But that means that about 90% of the cases have a completely mysterious etiology. And when we understand that little about a particular disorder, no wonder our attempts at successful pharmacotherapy have been fairly muted up to this point. So we kind of brought glutamate into the our vision in this particular approach to ALS treatment. And you can see that we're trying to dampen down the glutamate system, which is a little bit excessive in terms of Lou Gehrig's disease. In the next slide, I emphasized especially baclofen, which rather than being antagonistic, is agonistic as far as GABA is concerned, and that would make sense in that glutamate and GABA are often sort of a yin-yang pair, and as one goes up, the other goes down, and so probably not surprising that we're trying to increase GABA activation in terms of this particular emphasis here. And I briefly mentioned, just to create continuity between what we've talked about before, the potential for utilization of benzodiazepines for their ability to enhance GABA function. So that brought us to Alzheimer's disease, which is the Alzheimer's and related types of dementia is sort of the center of the area of frustration that we bring to neurodegenerative disorders, because, as this slide points out, extreme prominence of the disorders, but as we'll soon see, very little that we can do about that, even in a palliative sense. To some degree, we can ease some of the symptomology for a short period of time in this type of neurodegeneration, but not very well and not very long. And we just, going back to physiology, reviewed some of the physiology of apparent known physiology of AD, as well as other neurodegenerative disorders, which may not be Alzheimer's per se, but which are very similar to it. There's considerable, I'm not an expert on this area by any means at all, but I believe there's considerable thought in the field now that the so-called Baptist and Taoist approaches to understanding pathophysiology are fine, but maybe have led us down some not too fruitful paths in terms of understanding what the problems are associated with Alzheimer's, and that other different approaches to these um, protein-based approaches may be more useful in upcoming years in terms of inventing new, more successful therapies. And it'll be interesting to see um, what you folks are able to utilize in that particular regard in your lifetimes as researchers and clinicians. Yeah. So this is just, I think, about where we were uh, last time, and in terms of emphasizing a number of different um, neurotransmitters that are involved, acetylcholine and dopamine, which we've emphasized before, but to a lesser degree, serotonin and noradrenaline, which are going to be a bigger deal for us as we move into the antipsychotics. And of course, I don't even mention glutamate and GABA in this particular slide, but all these neurotransmitters, to some degree or another, are involved in dysregulation of neurodegenerative processes. So to address the fact that in Alzheimer's disease, basically it's a situation where there's too little cholinergic tone. In other words, in terms of absolute levels, too little acetylcholine in key brain areas. And the one of the approaches that's been semi-successful in terms of amping up the level of acetylcholine is by using cholinesterase inhibitors, which you can see. I'll just go ahead and read these bullet points to emphasize it delays worsening of symptomology for about a year at best, and for only about half the people that take them. So that's not exactly a resounding success story as far as treatment is concerned. I'm a little bit generous, I think, in saying that the side effects are generally well tolerated. About the only reason that they are is that the cholinesterase inhibitors that are utilized systemically for treating Alzheimer's disease are not as powerful of cholinesterase inhibitors as the ones that we talked about back in the autonomic drug area. If higher doses of more powerful agents were utilized here, the side effects would be substantial and very poorly tolerated. So, but in the particular case here of AAD, there are some different types of cholinesterase inhibitors that are utilized, and here is a list, a partial list of some of those. On this list, I would probably emphasize Aricept, which is up there on top, which is approved for utilization across the span of Alzheimer's disease. And then the last one, Tacrin, mentioned in the lower part of the slide, mostly for historical reasons, because Tacrin was the agent which was sort of initiated in terms of this strategy of dealing with Alzheimer's disease as being a deficiency of acetylcholine. But the limited nature, coupled with the adversity of this particular approach, suggests that in sort of treating cholinergic aspects of Alzheimer's disease, we're dealing with some fairly superficial symptomology, and we so far have not been able to gather ourselves to the point of addressing more basic deficiencies in this crippling disorder. Another approach that's taken is basically one that relates to glutamate. And you can see that memantine is utilized to improve particular cognitive aspects of Alzheimer's, including the attentional, memory-based, language-based problems that are occurring. And the progression, of course, of these items, ultimately leads to the situation where the individual who is affected by these matters has almost unrecognizable cognitive ability relative to the way they were earlier in their lives. So just a little bit of emphasis upon glutamate here. Katie can jump in and correct me if I'm wrong. But if I'm not mistaken, memantine is an NMDA antagonist. But again, not sort of promoting this as being the most powerful approach to treating Alzheimer's disease. It has its limitations, for sure. So there are many other neurodegenerative disorders that could be discussed. And if any time allows, as we wrap up here a few weeks from now, I may well address a few more, such as multiple sclerosis, which I didn't talk about at all in this series of lectures. So that brings us to the end of this particular segment. I'd be glad to try to address anyway questions if people have them. And while we're thinking about that a little bit, I'm going to switch over to our antipsychotic slide. I wish I could be more optimistic than I was. I'm pretty pessimistic, I think, as we went through this, as far as the degenerative disorders are concerned, because of frustrations that have occurred in the research field over the last couple of decades, which I think 2 or 3 decades ago, as we looked forward to 2020, I think we were expecting to be farther along than we are in terms of treating neurodegenerative disorders. So hopefully that frustration level will diminish during your lifetimes, and we can have a more substantial, successful approach to pharmacotherapeutics as well as other therapeutics involved in these all too common degenerative disorders. Anybody have anything question-wise at this point? Okay, well, let's switch to the extraordinarily important antipsychotic area. Sometimes these agents are also called neuroleptics, although that nomenclature is not as commonly encountered now as it was a couple of decades ago. So by antipsychotic drugs, the main antipsychotic drugs we're talking about are those that address schizophrenia. Now, some other things occasionally get lopped into the antipsychotic area, and I'll try to mention that a little bit as we go along. And we may encounter some of these drug substances in other related areas also, but I'll try during these lectures to sort of stick to the more traditional definition of antipsychotics as being anti-schizophrenic drugs. And I'm not sure how the week is going for everybody, but here's a nice little pose between Jelly Bean the dog and Olivia the black cat. And Olivia's the one that's camped out right beside me right now. The tranquil manatees. And that's sort of my other types of slides for this particular lecture. But I wanted to do some other things too as we were going into it. Now, peyote is certainly not an antipsychotic. It is sometimes accused of being, and I'm not sure if that's fair or not, of being a psychotomimetic, meaning an agent that mimics psychosis. So in sort of the contrary sense here, I'm producing a peyote as a hallucinogenic drug, and of course hallucination is part of schizophrenic psychosis. Um, so there was a time a few decades ago in which there was a lot of hope that by studying hallucinogens, we'd be able to better understand psychoses. But the psychomimetic characteristics of hallucinogenic drugs are not exactly those that we see in naturally occurring schizophrenia. So that approach, although still being looked at a little bit today, is not as widespread as it was a few decades ago. So on the antipsychotic side of things, here are some of the roots of the natural product rauwolfia, which reserpine is one of the active agents. So I thought you might like to see a little bit about that as far as reserpine is concerned, because it's been something that both Katie and I have talked about along the way, and in the history of pharmacology is a pretty prominent drug substance, even though its utility is not as great today, although as we just saw back with respect to Huntington's, still utilized today. Although in the United States anyway, seldomly in the antipsychotic realm, because we have more specific and less adverse agents available now compared to reserpine. But reserpine led the way into antipsychotic agents in terms of history. So from the standpoint of what we're talking about here, the Diagnostic and Statistical Manual 5 is the major worldwide source of diagnosis. I put in a subdivision here in substance use disorders just because we're going to be seeing that later on in the course, rather than putting it up for psychosis itself. But the DSM, is a big player for us in terms of a variety of things. Right now, psychoses, but later on in terms of misuse problems as far as other drug substances are concerned. So the DSM and other sources of information typically utilize the idea of so-called positive and negative symptomology as far as schizophrenia is concerned. Now, I have to admit, this is an area that has always kind of confused me a little bit and almost seems kind of backward. But in terms of it's not my place to second guess the experts in the field. So the experts typically define positive symptoms as characteristics that should be absent but which are present, and negative symptomology as characteristics that are absent or diminished anyway, and should be there. So I think that's a great place for us to stop. We'll continue on from this point as we pick up at 1 o'clock this afternoon, talk about various aspects of schizophrenia and how antipsychotic drugs are either successful, unsuccessful, or partially successful in addressing those various characteristics. So off to lunch, everybody. Prime up your parasympathetic nervous systems real well, get some good nutrition, and we'll be back in a little over an hour. Thanks a lot. See you then.